Okay, so hi, my name is Jillian. I'm an advanced care paramedic student here at SAIT, and I'm going to be walking you through the steps to a successful rapid sequence intubation. So a rapid sequence intubation is a combination of a sedative and a paralytic that is pushed rapidly through an IV push and in an attempt to get a good advanced airway placement. For our induction agents, we're going to be using ketamine. You can also use midazolam and fentanyl, but for our purposes, we're just going to concentrate on ketamine. So ketamine is a dissociative anesthetic, and it provides sedation by dissociating the limbic system from the rest of the cortex. The dosing for ketamine is 1.5 milligrams per kilogram, so we're going to be using a 80 kilogram patient. That means our dose is 120 milligrams. Indication for ketamine is induction for advanced airway placement. Contraindications for ketamine include hypersensitivity and any states where a transient increase in blood pressure would cause a negative clinical outcome, so someone may view as hypertension, ICP. Ketamine can also cause bronchial secretions and laryngospasm, so it's important to be aware of those things while administering the drug. What we're using for our paralytic is succinylcholine. It is a depolarizing neuromuscular blocking agent. Indications for succinylcholine are paralysis for advanced airway placement. Contraindications for succinylcholine include hypersensitivity, malignant hyperthermia, any elevated levels of CK, so that's a myopathy disease, and as well as hyperkalemia. Succinylcholine dosing is also 1.5 milligrams per kilogram, so for our 80 kilo patient, we're going to do 120 milligrams. After we've successfully placed the ET tube, we want to do a maintenance of paralysis and sedation as well. We don't want our patient rejecting the tube in any way. Signs of rejection of the tube include tearing, bucking, hypotension, hypertension, and tachyarrhythmias. So for our maintenance of paralysis and sedation, we're going to be using ketamine again. The dosing is 1 milligram per kilogram, so we're going to be giving 80 milligrams for maintenance. We don't want to be pushing any maintenance until we've confirmed that our ET is successful. All right. So that we've gone through our pharmacological agents, I'm going to perform the checklist as we do with every intubation, and we'll debrief our team or pre-brief our team and prepare for intubation. So guys, have we performed our lemon assessment?
Yes. Yeah.
Okay. And we have our BVM 2-man ventilations?
Yes.
Okay. We have our nasal cannula at 15 liters a minute?
Yes.
Okay. Oxygen is flowing?
Yes.
And they're in the proper position?
Yes.
Perfect. We all have our PPE on?
Yep.
Monitors on with ETCO2 connected?
Yes.
Vital signs have been assessed and considered?
Yep. Yep.
Okay. Suction tested?
Yep.
McGills are near the patient's head?
Yep.
We have our laryngoscope with appropriate blade?
Yes.
ET tubes?
Yes.
Yes, perfect, with the 10 ml syringe attached.
Yep.
Yes.
Stylet and bougie if we need it.
Yep.
Yep.
EDD, rescue airways.
Yes.
Craig kit and basic airways.
Yes.
Okay, and ETCO2 is working.
Yes.
And we have our ETT holder under the patient's neck.
Yes.
Okay, so we'll go over a little bit about pharmacology. So right now I have a 1 liter bag of normal saline running. What we want to do is avoid any instances of hypotension that can occur during intubation. There are parasympathetic and sympathetic nerve fibers in the larynx. So when you do a direct laryngoscopy, you can either have a tachyarrhythmia, you can induce hypotension or hypertension. So we want to do everything we can to avoid those instances. In terms of pharmacological agents, we can use as a prophylactic treatment. You can give atropine for bradycardic states, you can give fluids, and you can also consider vasopressors to support blood pressure. Perfect. So now that we've gone through our checklist, my team members have already delegated tasks, so they're prepared to intubate, and I'm going to be administering some of our pharmacological agents. So first we're going to go ketamine, so we're looking to sedate our patient. This is pushed over 30 seconds. And what we're looking for with sedation is a state of catatonia as well as unresponsiveness, but we want them to maintain their own airway. So pinching off at the top and pushing 12 milligrams or 12 mils over 30 seconds. This one has a clip on it too. Sorry. Perfect. So 12 mils of ketamine have gone in. As I mentioned, we're looking for signs of sedation. So assessing our patient, we want to assess their level of consciousness, and if they're looking a little bit dissociated, once they do look dissociated, we can move on with succinylcholine. It takes about a minute to work. So at this point, is our patient appropriately sedated?
They are.
They are, perfect. So we'll move on to succinylcholine. So the paralytic agent is also pushed over 30 seconds. It takes between 60 and 90 seconds to work. With succinylcholine, we cut and expose all the clothing off of our patient, and we're looking for fasciculations. Fasciculations are small muscle spasms that occur because of the depolarizing nature of succinylcholine. So you're going to be looking at the feet to the head and looking for small muscle twitches. I'm going to have both of my partners, one looking at the head and one looking at the feet. So we're good to go with sucks. I'm going to start pushing that now.
Okay.
Okay. So again, looking to my patient for signs of fasciculations. And it does, like I said, take 60 to 90 seconds. So now we're going to start seeing some at the feet, some at the abdomen, and I'll have Jevin looking to see when the fasciculations are complete at the head is when we can start our intubation. Jevin, do you see fasciculations?
Starting to see him at the head. See him at the forehead. Okay.
Okay, you can intubate.
One more breath in. 1, 2, 3, 4, 9, 5, 6, 7, 8, 9, 10, 11, 12, 13, still at 9%, 15, 16.
Perfect. So just like with any other intubation, we are going to do our 6 confirmations. So the first being the EDD, checking for reinflation. The second is listening over the epigastrium, looking for absent sounds. Then auscultating over left apice, right apice, left base, and right base. We visualize the tube passing through the cords. We've seen misting through the tube. And we're also looking for a gold standard of ETCO2 waveform. Perfect. So do we have our 6 confirmations?
Yeah, lungs are clear bilaterally and no epigastric sounds.
Perfect. So after our 6 confirmations, we're going to use our Thomas tube holder, and as well we're going to get a full set of vital signs prior to administering our maintenance of paralysis and sedation. Once I get my vital signs back, as long as they check out okay, I'm going to be pushing 1 milligram per kilogram of ketamine to maintain sedation. Okay. And vital signs are okay?
Vital signs are good. SpO2 is at 98%, and vital is at 33.
Okay.
Heart rate's at 73. Blood pressure is 106 over 70.
Perfect. So we push the maintenance of paralysis and sedation. The purpose of the maintenance dose is to make sure that they don't reject the tube, because we don't want them to be resisting our ventilating for them. We will also run through our dope mnemonic if there are any problems. So if we notice any difficulties with bagging, we're going to go through our D, which is displacement. So we'll check at the teeth, make sure that it's still where we marked it down. If it's not, we can reposition and do our 6 confirmations again. Moving on to O, we'll check for any obstructions. So if there's any fluid, we can do a deep tracheal suction. P is pneumothorax. As with any positive pressure ventilation, you run the risk of causing a pneumothorax and potentially leading to a tension pneumo. At that point, we can do a needle decompression. The last thing we're looking for is equipment, so we'll make sure everything's plugged in and used appropriately. If at any point we run through our dope mnemonic and we cannot correct the difficult bagging, we will extubate and attempt to place a rescue airway.